For our next session, it will be on online session by Dr. Michelle Dunphy, all the way from Ireland. Dr. Michael Dunphy is an emergency consultant at Cork University Hospital, and he will be talking about reorganizing trauma system utilizing registry data.
Good afternoon. My name is Dr. Michael Dunphy. I'm one of the consultants in emergency medicine and trauma in Cork University Hospital. And thank you for inviting me to speak at the MTR Collaborators Conference. It's a pleasure to be here. My talk today is on reorganizing trauma systems utilizing registry data. And what I specifically want to talk about is how the Irish trauma system was reorganized using data from the major trauma audit that's been running for the last few years. So before I go into details, I might just clarify what we mean and what we're covering in a major trauma audit. So a major trauma audit really collects information on patients. It collects information on patients who become injured, on the injuries that they've sustained, how they've come into our hospitals, the care that they receive when they're in our hospital systems and even pre-hospital. It looks at outcomes, information on outcomes, both positive outcomes, negative outcomes, and it also looks at deficits that might have occurred in the care of these patients. And as you can understand, this information is very, very useful to our hospitals as they can begin to review their own data and information, and they can start to identify in their own hospitals good outcomes and deficits in care. But most importantly, they can learn from this information and they can apply the information that's gathered in the major trauma audit to drive research, innovation and quality improvement projects and measure the effects of those improvements that they're trying to make. And that really completes the circle of audit that we're undertaking. So the major trauma audit really helps us to establish a baseline of the trauma practice that's taking place in Ireland at present. It helps us to map that practice, how it applies to the patient on their journey through the hospital, and to look for ways to potentially improve the current pathways of care that exist in our hospitals. We also wanted to promote and generate reflective clinical practice, both at a local level in individual hospitals, and also at a national level in terms of driving policy. And finally, our major trauma audit provides us with a robust, high quality of data that we use to enable peer-reviewed research and to drive clinical changes in our practice. And it's with clear objectives like these, these clear objectives are absolutely critical when setting up a major trauma audit in order to assess how your audit is working. Now, before I go into a talk on data and statistics and processes, I want to start really with a personal story, with a patient's story. This is a case that occurred for us about 5 years ago now. We received a call from our paramedics that there was a gentleman working on the roof of a factory near the hospital. He was about 20 feet up and he had fallen through the roof. And the pre-alert came in that they were bringing in a hypotensive, tachycardic, so profoundly shocked patient with multiple injuries. So this patient was met in our resus by our trauma team, and his injuries, as I said, were multiple. So he had a fractured scapula and injuries to his chest wall. He had a pneumothorax. He had a small hemothorax. He has significant severe injury to his pelvis from the fall, with significant bleeding into the pelvis. He had a long bone fracture, so he had a comminuted open femur fracture. And he had significant head injuries as well, with fractures to the right temporal region and the right orbit. Now, In order for this man to survive and have a good outcome, a good recovery from this, all the links in the chain of survival have to be intact, from his pre-hospital care, his reception in the hospital, the treatment that he gets in the emergency department, treatment that he gets in the operating theatre and the ICU, and the treatment that he gets in his rehabilitation from these injuries. But in Ireland, for many years, the situation that we faced were that the links in the chain of survival were weak, and the links in the chain of survival were somewhat scattered around the country. So historically, we faced a situation where we had a total of 26 hospitals that normally receive trauma. So we had two, at either ends of the country, we had 2 adult neurosurgical centres. We had another centre that specialised in pelvic injuries. We have another hospital that specialises in spinal injuries. We have a hospital that treats burns. We have several hospitals that treat cardiothoracics or plastics injuries, and other hospitals that treat maxillofacial injuries. But in no hospital really were all these services combined into one centre. So for a patient who's being brought to hospital with multiple polytrauma, the dilemma is, which hospital do you go to? Do you go to the nearest one? Do you go to the one that the suspect is going to treat the suspected head injury? Do you go to the one that's going to treat him for his pelvic injury? And whichever hospital this patient goes to, the challenge then is to transfer him between these other hospitals that provide specialist care. So to begin fixing this problem, it was necessary to measure it so that we could get a grasp of what's going on. And the trauma audit really enabled us to see where we were at in the Irish context, and to use that information to inform us of how our trauma networks could be developed in the future, and that if we were going to make changes to our trauma system, that we would have a way to monitor the effect of those changes that we make. There's a famous industrialist, William Edwards Deming, worked for Toyota in Japan, and he came out with a famous statement of that you can't manage what you don't measure. So if you don't measure what's going on, it's very difficult to fix it. It's very difficult to correct it and to know that your corrections are working. So the question of what do we measure in our data collection is important. Let's give context really on it. We're looking at patients like that man who fell from the roof. We're not talking about trivial trauma. We're not talking about isolated injuries here. These are patients who have typically multiple injuries, who have severe injuries, who will spend usually 3 days or more in our hospitals. These are patients that are brought to our ICUs, or patients that are transferred in and out of our hospitals for ongoing care. These patients have a high cost to the health system as a result of their injuries. But they're patients who've sustained either life-threatening or life-changing injuries, because that's the nature of the level of trauma that we're dealing with in our trauma audit. And we collect pieces of information from across these patients' journeys, from the pre-hospital setting. So we look at how long it took them to get to hospital, what were their initial observations, what medications did they receive pre-hospital, what treatments did they receive pre-hospital. When they arrive in the hospital, we look at what care did they get in the emergency department. Was there a trauma team there? And if there was a trauma team, what was the level of experience and seniority that was in that trauma team? We look at things like how quickly did they get into a CT scanner? How quickly did they get to the operating theatre? What was done in the operating theatre? And how long did they spend in hospital? How long did they spend in the intensive care? And thanks to our trauma audit, we now have all of those metrics recorded with a very robust methodology for doing it. Now, what we do with all this data, well, one of the most important things that the data gives us is a view of the changing face of trauma. So there are lessons to be learned in the demographics And we can see just by looking at the median age of the patients presenting with trauma, that trauma is no longer, a disease of the young person. Trauma is no longer just the 20-year-old who goes out and gets drunk and has lots of Red Bull and drives his car really fast and hits a telephone pole. It's not that at all. In fact, more than 50% of our trauma nowadays is in the older age group of 65 years and older. In addition to that, at least 54% of our major trauma occurs amongst people who are potential taxpayers, so people who are working age. And that has important implications for policy, because politicians quickly realize that 54% are in the age group of 16 to 65. So knowing that the demographics helps us in terms of predicting what treatments will be required, and importantly, what preventative strategies we should be using to avoid these events happening in the first place. And when we look at the cause of injury amongst this changing population, many of us, we would think of trauma might have been like the case I presented earlier of a working age gentleman, involved in an accident at work, a fall from height, or, a car hitting a lorry or what have you. But in actual fact, that's not the case. Most of our trauma now arises from falls, usually of less than 2 meters. So typically that's a fall from standing height. And that's what we're seeing most frequently as a #1 cause of major trauma in our population. Second to that then would be road traffic accidents amongst the younger group. What we see as well in the data, at the lower end of frequency of presentation, but much more lethal, are things like asphyxia and drowning. So that's typically someone who's hung themselves or drowned by accident. And it's in that area that you see there's the interaction or the potential for interaction between our trauma data and social care, psychological and psychiatric services interacting with the trauma services. Because in those cases, asphyxiation typically presents those people who've come to hospital they've hung themselves, okay, or they've survived to get to the hospital, but they make up much more of the deaths in this trauma registry than patients in any other group. So it's a very lethal method of injury. So just going in a little bit more detail about the injuries. This is the most recent publication. This is from 2019-2020, our trauma audit. So what are the injuries that constitute major trauma? Well, 23% of them are major head injuries, severe head injuries. 16% are spinal injuries. And about 8 or 9% of our patients have multiple injuries. About 30% of our patients need to be transferred on from their initial hospital to another hospital for definitive care. So that's typically in the case of head injuries needing transfer to a neurosurgical centre. But sometimes it involves patients transferring for specialised plastics, burns or cardiothoracic care. Head injuries in particular group that we need to pay attention to. We need to be cognizant of head injuries because it's such a catastrophic, devastating injury for the patient and their family. And within a moment, their life completely changes. An international best practice would say that people with a head injury with a Glasgow coma score, which is a coma level of 8 or less, that means that they're deeply unconscious. These should have access to specialist treatment by neurosurgeons. And what we see in Ireland in 2019-2020 is that 43% of severely head injured patients in Ireland are treated by neurosurgeons. And of that 43%, 20% were transferred from the receiving hospital to a neurosurgical centre. In terms of the time that trauma happens, I think anyone who went into emergency medicine hoping that they would have a 9-to-5 office job hours is going to be sadly disappointed. most of the trauma work that happens in our country occurs outside of 9 to 5. So about 60% happens between 4 p.m. in the afternoon and 8 o'clock in the morning. And that has important ramifications in how we develop our trauma system, in how we staff our emergency departments, in how we roster our consultant cover, and how we organize our trauma teams to make sure that the hospitals are prepared for the trauma patients who are brought into their emergency department, you know, outside of main working hours. Speaking of trauma teams, front door trauma teams are associated with improved access to critical interventions and improved access to, improved clinical outcomes. And for whatever reason, we've really struggled to get traction on this in Ireland. So the numbers of patients presenting to our hospitals who are met by a trauma team, so that's a team gathered that's a team gathered together in the emergency department to receive trauma. These numbers they're really low, and we've had real difficulty getting an improvement in them. But we're capturing this, and we acknowledge that, you know, the number of those teams that are receiving patients that are led by a consultant is low. And some of that may be that they're just not used to documenting it, or it's not being recorded properly in our audit. You know, the consultants are coming in, but they're not documenting that they're seeing the patients, or they're supervising work without necessarily documenting that they're supervising it. But nonetheless, it's definitely an area that we need to pay attention to. And in November 2020, the Irish Association for Emergency Medicine released a position paper on trauma teams and trauma team responses that advocated a two-tier response for trauma. So tier one would be emergency department level response, so consultant, senior emergency medicine doctor, and whoever they felt was necessary. And then tier two would be a hospital-wide response with you know, surgeons, orthopedics, neurosurgery, anesthetics as required. So other information that we can get from our major trauma audit, we can use our major trauma audit to predict what the ICU bed capacity for trauma should be, and what ICU capacity is required in our hospitals. And we can see where the ICU, and we can see where in the country that ICU capacity is required. We can look at the length of stay. So we know that the ICU length of stay for trauma, the median ICU length of stay is 2 to 3 days. And the hospital length of stay for major trauma is 9 days, usually, right, going up to 11 days in the case of those patients with a higher injury severity score. But aside from the data of how long people spend in hospital and what happens to them in hospital, what we're really interested in and what really matters is outcomes. But outcomes can be difficult to interpret, and outcomes can be too binary sometimes. So to say that a patient lived or died doesn't give us enough information. Okay, what we're really interested in is not so much who lived or died, but the unexpected outcomes. So by that I mean the patients who survived that we didn't expect to survive, or weren't expected to survive, or the patients who died when we would have expected them to survive. And we need that risk to be adjusted as well to account for, you know, age and comorbidities, because an 85-year-old that crashes their car is a very different type of patient to a 20-year-old who crashes his car. So comorbidities and associated illnesses are very different, and we need to risk adjust for those. But when you look at the mortality and look at those that died across age groups, there are a lot of interesting findings. When we look at our pediatric age group, thankfully there weren't ever too many children captured in this group, but 75% of the children who died were male, and the median age was 11. Okay, so it's not the 1 or 2-year-olds that are having major trauma and dying. It's the 11-year-olds who are presumably engaged in riskier activities. And we could see that 13% of the deaths in that age group were either due to asphyxia or hanging or drowning. And the median injury severity score that they were having was very high at 25. And when we go up in an age category, when we look at those in the working age group, so the age group of 16 to 65, it's in that group that we see a big difference in sex. So many more males in that age group are suffering trauma. And again, you see the interaction there between social services, psychological services, psychiatric and major trauma, because 28% of those deaths were due to asphyxia or drowning, which is a significant portion of which, much of that would have to been deliberate self-harm. Interpersonal violence is prevalent amongst this age group too, and we are seeing an increase in knife-related violence in Ireland. And in the UK, trauma centres are working closely with first responders, paramedics and the police to provide advice on how to manage knife injuries, and they're setting up violence reduction units to look at reducing gang-related violence. Road trauma is the second, remains, a major cause for injury in this age group. And the data from the major trauma audit can be used in public health targeting of younger drivers. And then we go on to the older age group, and you can see a balancing up here of that male-female distribution. So no longer, a male dominance of injuries. A much greater proportion of this age group are people who have falls less than 2 meters. So that's the elderly person who falls over at home. They fracture their wrist, they bang their head, they fracture their pelvis. And these are initially brought to their local emergency departments rather than to major trauma centres. And the level of injury is often under-triaged, underappreciated, because of the relatively innocuous way the injury was sustained. So we expect major injuries when we come to a road traffic accident, and we're less likely to expect major injuries when we come to someone who's fallen over in their kitchen. But older patients are less likely to generate, as a result of this, older patients are less likely to generate a pre-hospital trauma alert. They're less likely to be received by a trauma team or be reviewed by a senior clinician. And older patients are much more likely to die and less likely to be discharged home following major trauma. To go into the data just a little bit more, the WS score is a very important measure, and it's something that gives us very meaningful information in that it looks at the probability of survival for each individual patient, but it contextualizes it then to all the patients. So what we know is that in Ireland, the WS score for the whole country is 1.25 in 2020, which means that for every 100 patients that present to Irish hospitals with major trauma, there are 1.25 excess survivors or extra survivors. And it's good that it's not a negative number. If it were, minus 1.25, that would mean that we would have 1.25 excess deaths. But we can see, here the confidence interval is positive, although there is a caveat here that we haven't got 100% data coverage. We're averaging 78% data coverage in 2020. So we had data on 78% of our patients, and it might well be that in future years, when we increase our data coverage and we're getting that extra 22% of patients that aren't captured, that the WS score might change. It might not. It has been pretty consistent since 2016 when we first began publishing it. It's been consistently around 1.2, 1.5 mark. But most importantly with this, what we do see And what all hospitals now have access to is their own metrics compared to other hospitals in Ireland. So each hospital knows what its WS score is, and they get to look at themselves and they get to look at their other peer hospitals, and they can see what their WS score is in comparison. And that serves to create a bit of competition between hospitals. And it's that competition is fundamental in driving quality improvement in the system across hospitals. And what we see at the moment is that there's variation across the system, and it gives us, in terms of data collection, it gives us a space to watch. But as I said, in terms of outcomes, mortality is a crude outcome. Survival is a crude outcome measure of quality. The space that we really want to get into in the major trauma audit is our functional outcomes and the quality of life outcomes for these patients. Because as you can see from this graph, only about 5%. Excuse me. As you can see in the graph, only about 5% of the overall group of major trauma patients die. But a lot of these patients have life-altering injuries. And really the question that we're trying to capture is, would these life-altering injuries have been so bad if the treatment processes had been different? And we don't know that. And we need to look at that, and we're taking steps to investigate that now in terms of rehabilitation needs and rehabilitation prescriptions. And we're trying to look at monitoring functional and quality of life outcomes rather than simple life or death outcomes. So what we have now, really as a result of the major trauma audit, is for the first time in Ireland, we have a robust data set that we should be and that we are using for both quality assurance and quality improvement. Hospitals that are licensed for major trauma now in Ireland have to show that they have a trauma or governance group in place in hospitals, and that trauma or governance group oversees the implementation of their trauma audit and the output from that audit. And a governance group is, comprised of stakeholders in trauma care in that hospital. And the audit as well can be used to monitor equity of access to care, and that's important for patients. It's important for political reasons as well, so that the politician in Dublin can look. He's worried about his constituents and his patients. He can look and see what the outcomes are for his population of people, just as much as a politician in Cork can look at and see how patients are doing here. And these people can go on and advocate then for their hospitals, for funding and for improvement. So as I mentioned, what we have now since 2016, the publication of the first major trauma audit, the national report, to our most recent report published in 2022, which was delayed by COVID, is a robust set of data for Ireland in terms of our trauma management and our trauma care. And the data from our major trauma audit is used to help with decision making in the areas of trauma prevention, through to pre-hospital care, to resuscitation care, to rehabilitation, to ensure ultimately that all patients have access to the right care in the right place at the right time. Looking to the future a little bit, and current and exciting developments in terms of trauma audit. One of the recent innovations has been the deployment of TARN dashboards. So TARN has now developed an interactive data analytics portal that can be accessed on their website. And hospitals now can access their own data and create live reports of specific categories. And this type of information technology gives hospitals the ability to use the data contemporaneously, to use it quickly, and it helps to facilitate quality improvement and service development in a supportive manner. Ultimately, the major trauma audit and the interpretation of its data is about delivering change in our trauma care. And the data from the major trauma audit continues to inform key system changes in Ireland, such as a reconfiguration of the trauma system and the designation of major trauma centres and trauma units as advocated for in our national trauma strategy. I spoke at the start about the links in the chain, about how they were scattered around the country, and we spoke there about there being various hospitals specialising in single aspects of trauma care, such as burns or spinal injuries. And moves have been underway in Ireland for the last few years and will be going on into the future to consolidate our trauma care into two regions, with a major trauma centre at the heart of each region. So there's going to be one major trauma centre in Dublin, covering the east, the west and the north of the country, and there's going to be a major trauma centre in the south of the country based in Cork, where I work, which covers the majority of the south of the country. And these major trauma centres provide the highest level of specialist trauma care to the most severely injured patients, all on a single hospital site. So avoiding that dilemma of where do you go to get your pelvis fixed versus your head injury, your spinal injury versus your cardiothoracic injury. And it's the establishment of these major trauma centres really represent a huge milestone in the development of the trauma system in Ireland. And it will see major trauma care coordinated and dedicated by receiving and inpatient trauma teams. Patients suffering from major trauma in Ireland now will have their medical, surgical and rehabilitation care all coordinated by a dedicated trauma team. We spoke about measuring outcomes. Each trauma patient now will have their rehabilitation needs assessed within 48 hours of injury, and where required they will have a rehabilitation prescription that will be completed and will follow the patient during their recovery from trauma. And we hope that this will assist in development of trauma and rehabilitation outcome measures that we can include in future audits. The major trauma audit ultimately enables these hospitals and these major trauma centres to measure their care against defined clinical standards in a transparent way that is visible to everyone who cares to read it. And in addition, it supports active engagement and quality improvement that can be shared between hospitals. And it's that synergy between care standards, audit and feedback that ultimately drives measurable improvement in outcomes for patients. On that point, I'd like to thank you all for listening to my talk. I'll be available for a question and answer sessions at the end of it, and I really look forward to any questions that you might have. I've included here a link for the main website, the National Office of Clinical Audit in Ireland, where all the publications that I referred to in this talk can all be downloaded and read through. And I fully recommend that you take a look at it if you're interested. Thank you very much. It's been a pleasure.